And we're live.
Good evening, everybody. We are back again. I think this is our third edition of um, Pasifika Grand Rounds, and we are with the Happy HAPI organization. And we're basically going through different presenters over different topics. And we're in this series, we're three deep into, I think, Dr. Samoa, do we have 11 planned?
Yeah, I think right now we have 11 slated.
Okay, so we have Dr. Jana Dickter, who is going to be it's going to be our premier, our keynote speaker, and then I'm going to go ahead and let Dr. Samoa make the introductions, and then we're going to come back for a question and answer section at the end. This will also be recorded and put on. It will definitely be on Pasifika by Design at Pasifika by Design on Facebook and YouTube. And then, Dr. Samuel, are we putting this on any other platforms?
I think on the Happy Facebook page, we've been putting the links to the recordings, the YouTube recordings.
Okay. So there will be different ways to get these. And then I think there's a new portion that I'm going to let Dr. Samoa talk about, the continuing education units that are now the program is eligible for. But
Right.
that's the show today. And I'm going to turn it over to Dr. Samoa.
We are legit. So we just started offering continuing medical education credits. And we'll talk a little bit about that towards the end as well. So as you know, the Pacifico Grand Rounds is a forum for networking, but also for to provide education to medical providers that service Pacific Islander and Native Hawaiian communities. And so the partnership between Pacifica by Design, the Healing Association of Pacific Islander Doctors, or Happy Doctors, and the Mapumaya Clinic, that's affiliated with Utopia, Washington, has pulled their resources together to provide a lot of this information. And so the topics have been identified by not only the Happy Doctors, but by the staff of the Mapumaya Clinic. We also accept recommendations for topics on our Facebook pages as well as in the chat. And so, for that reason, HIV care has been brought to the attention of the group as a much needed area for discussion and information. And I'm extremely happy that we have a world class expert in Dr. Jana Dickter. Dr. Dickter earned her undergraduate degree in cognitive sciences from the University of California, San Diego. She went on to receive her medical doctorate from Rush Medical College in Chicago. After an internal medicine residency at the University of Pittsburgh Medical Center, Dr. Dichter began her fellowship at the UCLA affiliated program in infectious diseases. Dr. Dichter has over 20 years of experiences in clinical infectious diseases. She's worked at Kaiser Permanente over 10 years as an ID specialist. She had a robust HIV practice. She joined City of Hope in 2016. She's board certified in internal medicine and infectious diseases, and is also certified by the American Academy of HIV Medicine. She's interested in clinical trials and chemistry for people with HIV. For many of those who recognize Dr. Dichter, she has been featured in the media as a year ago as a provider of a patient who is in HIV remission after receiving a stem cell transplant. And so, with no further ado, please help me welcome Dr. Jana Dichter. So I'm going to share our screens. Okay, you tell me if you see it, okay?
Okay, I see it. Can everyone hear me?
Yeah, I can hear you.
Okay, great. All right. Well, thank you for this invitation. I was really happy to receive it, and And I always love talking about HIV because this is what I'm is definitely one of my this audience is
Jana, can I make a recommendation? If you have any, for some reason you're freezing, you're
yeah.
frozen a lot. Do you mind if is there any way possible if you can close any of the other apps you have on to see if that helps at all with the
Yeah, I don't have any other apps. So, well, I'll close my email, I guess. Yeah, else on. So
Okay.
is this better?
Yeah,
All right,
it's a little more
great.
clear now. Yeah.
Okay. Okay. Usually I don't have technical issues. That's weird. Okay. So I'm guessing that everyone in this group, it's different kinds of physicians, right? Different specialties, multi-specialty group. Yeah. Okay. All right. Well, today I was invited to discuss an overview of HIV care for non-healthcare providers. Am I still breaking up?
No, I can hear you.
Okay. Okay. So can you go advance to the next slide?
Sure.
Okay.
Uh,
Or do you want to give me control of the slides? Would that be easier?
no, I can probably do it from here because I wouldn't know how I could do that for you. No disclosures.
Okay.
Okay. All right. Does that work?
Okay. So the HIV comorbidities of HIV in the aging population, HIV management, monitoring for complications and preventative care, and also preventative strategies. Can we go to the next slide? Okay, and then the slide after that, please. All right. So I'm going to just remind everyone about the life cycle of the virus itself. As you can see from the slide, it's broken down into 7 different steps. There's binding, fusion, reverse transcription, integration, replication. Medications that we use are working different parts of this viral cycle, which I'll highlight in the different steps. But the first step is when HIV attaches itself to a receptor and then uses a co-receptor, either CCR5 or CXCR4. And there's 2 different classes of HIV medications that work at this step in the life. And then during the second step, as you can see, the HIV viral envelope fuses for cell membrane, and HIV then enters the cell, the CD4 cell, and once the virus is actually inside the cell, the virus will. So these enzymes include reverse transcriptase and integrase, and the HIV medications that work at this step in the second step are called fusion inhibitors because they prevent the fusion of the virus into the cell. At the third step, HIV releases and uses an HIV enzyme called reverse transcriptase to convert its genetic material, HIV RNA, into HIV DNA. And this conversion of DNA. The HIV drug classes that will help block this step are nucleoside reverse transcriptase inhibitors and non-nucleoside reverse transcriptase inhibitors. Those are NRTIs and NRTIs. And then in the fourth step, when HIV is in the host CD4 cell nucleus, the HIV releases an HIV enzyme called integrase, and the virus uses integrase to integrate itself or insert itself into the virus. Is most effective that is effective at this step in the cycle is the HIV drug class integrase inhibitors, and they work to block the integration of the virus into the DNA. So then in the fifth step, now that the HIV is integrated into the host CD4 cell DNA, the virus then uses the CD4 cell machinery to create long chains, and these protein chains are called the building blocks to make more virus. And then moving on to the second step, the HIV RNA is into the cytoplasm and up to the surface of the cell, where it can assemble into immature non-infectious HIV. And finally, at the last step, it's called budding, where this immature or non-infectious, it is something called HIV enzyme, and it breaks up, creates the mature or contagious infectious virus. And the class of drugs that disrupt this part of the cycle, the last part of the cycle, are integrase. Okay, next slide, please.
Jen, it seems to be freezing every now and then. The IT people here says
Okay.
that maybe if you turn your camera off, it
And next
might.
slide after that. I'm so sorry. Okay, can you hear me now?
Yep. Yeah, we can hear you now.
Okay. All right. Yeah, I don't know why it's doing this. So I'll talk about the H 2 million. He recommends that everyone um, between the ages of 13 and 16 as a routine part of their care. And the reason for this is because about it's 7 people don't know that they have HIV. For people who have more risk factors, it's recommended to test, including racial and ethnic minorities, gay and bisexual men, and men who have sex with men. Oh, I can turn your camera off. Okay. Okay, maybe that's better.
Yeah, I can. It sounds.
Next slide. Am I still cutting in and out?
A little bit.
All right. Let me turn off my phone 1 second. Maybe that'll help.
Okay.
Okay. I hope this works. Okay, so this data looks at new HIV diagnoses during, and this should be interpreted with caution because of the impact of the COVID-19 pandemic on access to HIV testing, care-related services, and case surveillance activities in local and state jurisdictions. The overall United States in 2020 was 17% lower than in 2019, but this decline was significantly larger compared to the preceding guidelines declines, which were roughly 2 to 3% a year. And again, 2020. During 2021, the overall number of HIV diagnoses rebounded to of HIV diagnoses that were missed in 2020. The ongoing impact of the pandemic on HIV testing, diagnosis, and next slide. More locally, in 2020, the number of people living 595 out of every 100,000 people. And as you can see, this is one of the darkest shaded regions on the map, the LA County area. Next slide, please. And when looking at new diagnosis in LA County in 2020, there were 16.4 new cases out of every 100,000 individuals. And this number likely underrepresents the true new positive infections. As such, we can expect to continue to see newly diagnosed HIV patients. Next slide, please. So gay, sexual, and men who have sex with men are the disproportionately affected by HIV. And in 2021, men who have sex with men accounted for 67% of the new HIV diagnoses. And part of the stigma, healthcare, discrimination, homophobia, and these inequities drive and influence healthcare outcomes. Next slide, please. And while HIV affects all races and ethnicities in the United States in dependent areas, some groups are disproportionately affected compared to their general population. Among new HIV diagnoses in 2021, 69% were either Black, African American, or Hispanic, Latino, or Latinx. And similarly to what was mentioned previously, this is again due to the disparities in diagnosis, barriers to healthcare, discrimination, homophobia. Next slide, please. But the population of people with HIV is changing demographically, and due to the success of antiretroviral therapy, the HIV population is aging. 5 years ago now, over half the people with HIV were over age 50 years old. Now, with this aging, there's also an increased risk of comorbidities that are associated with aging. Next slide, please. The success of anti-improved dramatically since its inception in the almost over 30 years ago. And early on, there was only one class of medications available, and these drugs had fairly significant adverse side effects. And there was also a lot of medications that you had to take at one given time. Also, the virus developed resistance when these medications were used as individual agents. In the mid 1990s, new classes of drugs were introduced, and studies showed that combination treatment was effective in controlling viral replication precipitously in countries where these medications were available. Today, in 2023, there are 8 different classes of medications.
Becky and Carl, is there a call-in line that Dr. Dickter could use probably to finish her presentation?
I'm not aware of a call-in line. We can check to see if there's a way to do that through the phone, but I'm not aware of one at this point. But
Right.
um, are you familiar with the slides at all? Or is there a different piece of um, the presentation we can go to see if she ends up getting a better connection and can come back to us?
Let me see. Yeah, because I think it's a connectivity problem. Um,
Let me
I
check.
don't even want to pretend that I'm an expert in HIV care. Let's see. Give me one sec. Oh, we just got to the part where it's kind of pertinent to the rest of us. Let me see. Give me one sec.
Certainly, certainly. And if we need to, if this is something we need to redo when there's better connection, it's obviously something we can do another time, but hopefully we're able to work through this and be able to get Dr. Dickter back on. Let's see. Here we go. Let's try that. Yeah, it's
She back
still,
on?
yeah, I brought her back in. Can
Okay.
you hear us, Dr. Dickter?
Okay. I can. Can you hear me?
We can right now. I will go ahead and drop and hopefully we can continue.
Okay. Yeah, I don't. Okay. All right. So that graph actually just shows the demographic change in people with HIV in the um, among the older population And as you can see, a much larger percentage of the people living with HIV. And this is due to the success of antiretroviral therapy. Next slide, please. So treatment with, one slide back, please.
Hold on, we're kind of losing you. You know what I'm gonna try to do? Do you mind if we if I'm gonna try to if you use your cell phone, maybe we can get more consistent audio.
I can
if I just
try
put
here.
your
Let me
yeah,
here. Let me. It's really
just answer.
good connection.
Yeah, I don't know why ours isn't showing up very well, but if you answer your phone, maybe I can put you on speaker on my mic.
Okay.
Okay. I'm calling you right now.
Do you want to call me?
Yeah, is that your number? I think I'm calling your number right now.
Here. Okay.
Let me try calling you again. Is it not going through? I can hear you.
Hi. Can you hear me now?
Give me one sec.
Okay. Good. I'll mute my microphone, and that way.
Okay, so actually I was, can you go to the next slide?
Can you go to the next slide?
Okay. So,
Okay.
there's a population. The reason for the aging, as I mentioned, is due to the success of antiretroviral therapy and these chronic age-related changes.
As I mentioned, is due to the success due to aging, exacerbated morbidity. Examples of this include an increased risk of bone disease, metabolic disorder, more exposed to different risk factors that affect aging, such as medications and a back which has been associated
Carla, you saying mute the
with
Dr.
cardiovascular disease.
Dickter has to mute?
Next slide. Okay. So with the advent of effective antiretroviral therapy, the life expectancy for people with HIV is now approaching what is seen in the general population. And consequently, the relative importance of other traditional non-AIDS related comorbidities has increased. Next slide, please. So this study was published in Lancet in 2014, and it looked at the causes of death among individuals that were followed up from the data collection on adverse events of anti-HIV drugs. And this study included over 49,000 people. The top graph shows everyone in the study population, so that's A, and B, the lower half are only include people with undetectable viral loads. The rate of death has decreased pretty substantially between 1999 and 2000. It was 17.5 per thousand years, and which dropped roughly in half to 9.1 between the years 2009 and 2011 to 9.1 per thousand years. And this decrease in overall death remains after accounting for the aging population through the use of age standardized estimates. Similarly, there were decreases in deaths due to AIDS, liver disease, and cardiovascular disease. What's interesting is that light blue line there, you can see that is a cause of death associated with non-AIDS related cancers, and that was stable whether a person had in both the general population and among people with undetectable viral loads. Next slide, please. And of course, people with HIV should start antiretroviral drugs as soon as possible for viral suppression. Next slide, please. So, monitoring for complications and preventative care are key aspects of HIV care for today, including assessing cardiovascular risk, diabetes or glucose intolerance, evaluating for bone fragility, osteoporosis or osteopenia, looking for neuropsychiatric complications, age-appropriate screening for cancer, evaluating people for sexually transmitted infections, and looking for evidence of medication toxicity. Next slide, please. And there is an increased incidence in developing cardiovascular disease for people with HIV compared to the general population. Multiple studies have demonstrated a 1.5 to 2-fold relative increase in cardiovascular disease in people with HIV compared to the general population. And this was really substantiated in a meta-analysis looking at over 700,000 people with a follow-up of over 3.5 million person years. The risk ratio for cardiovascular disease was 2.16 compared to those without HIV. And what's really unknown is if this is due to HIV itself, the virus, which causes this, inflammatory response, versus other potential risk factors or medications that may contribute to increased risk of cardiovascular disease, specifically some of the older protease inhibitors and abacavir. And preventative strategies are important, managing the dyslipidemia, hypertension, diabetes, tobacco use, and counseling on exercise and diet. Next slide, please. People with HIV also have higher rates of hypertension compared to people without HIV, and monitoring for blood pressure issues is recommended annually. Just like in the general population, treatment is quite similar. It is the same as per the American College of Cardiology, American Heart Association. Next slide, please. And among people with HIV, dyslipidemia is common, and HIV itself, the virus, may impact dyslipidemia, and also certain medications can contribute. Most notably, again, the older protease inhibitors tend to be heavily associated with abnormal lipid profiles. What's interesting is the newer nucleoside reverse transcriptase inhibitor, tenofovir alafenamide, or TAF, which is now used almost, I don't want to say in everybody, but many people. It's a backbone drug in many of the regimens, has been definitively associated with elevated cholesterol, including LDL and total cholesterol. And it's unknown what the clinical significance of this is, but what's also interesting is this also appears to be associated with a significant weight gain in this population as well. Multiple guidelines recommend baseline lipid testing and retesting 1 to 3 months after starting a new antiretroviral drug regimen, and then annually thereafter. And management is the same as really for the general population. Lifestyle modification. You can consider switching antiretroviral drug therapy depending on what people's risk factors are, and pharmacologic treatment with statins. Something to consider, however, is that the current standard cardiovascular risk calculators do not incorporate the risk of HIV, and it's uncertain how you're supposed to navigate that when assessing a patient. So, you know, you may, for certain patients, you may want to consider initiating a statin sooner, but that is something to be aware of. And also, there are a fair amount of drug interactions with protease inhibitors and statins, so that needs to be evaluated as well before initiating any new medications. For another thing we do see in this patient population is severe hypertriglyceridemia, and in those patients, we recommend starting a fibrate in addition to non-pharmacologic therapy to help reduce the risk of developing pancreatitis. So managing hypertension, smoking cessation, diet, exercise, and decreasing alcohol consumption. Next slide, please. So glucose intolerance, or the development of diabetes, is also heavily associated with the earlier generation protease inhibitors, which most patients are not on anymore. Guidelines do recommend baseline blood glucose and or hemoglobin A1C checking before initiating a new antiretroviral drug regimen, and then rechecking every 1 to 3 months after initiating a new medication, and then annually thereafter. One word of caution is that hemoglobin A1C should not be routinely used to diagnose diabetes after antiretroviral drugs have been initiated, because the hemoglobin A1C test may underestimate glycemia in people with HIV. And it's recommended, rather than checking hemoglobin A1C, to check a fasting glucose or doing a glucose tolerance test. This is thought because people who have HIV are in a chronic low-level hemolytic state from either HIV, the virus itself, or from the medications, which can impact the accuracy of a hemoglobin A1C test. Management of glucose intolerance and diabetes is the same as for the general population: drug therapy and weight loss, and so forth, through diet, exercise, and also medications. Premature bone loss, osteopenia, osteoporosis, and fracture rates do occur at higher rates in people with HIV compared to age and sex matched controls. And some studies recommend doing some studies have associated certain medications with osteopenia and osteoporosis, notably tenofovir, the older drug, tenofovir, disoproxil fumarate. Also, some of the older protease inhibitors have been associated with bone loss. And it's recommended, the guidelines now currently recommend getting DEXA screening tests on postmenopausal women and men aged 50 or older, and treating them with calcium, vitamin D, and also assessing them for other reasons for developing osteopenia or osteoporosis, including hypogonadism or hyperparathyroidism. And for people who don't have any bone loss, then the screening is the same as the general population. For neuropsychiatric disorders, screening for depression and anxiety is important. HIV-associated neurocognitive disorders are definitely a problem in this population, and that can range from asymptomatic to dementia. Certain HIV medications have been associated with neuropsychiatric changes, specifically the older non-nucleoside reverse transcriptase and integrase inhibitors, and then also screening for substance abuse, tobacco use, drug use, etc. Next slide, please. And smoking cessation is really important. There was this population-based study in Denmark between 1995 and 2010, where the authors estimated the effect of smoking on all-cause mortality and on risk of death caused by cardiovascular disease and cancer. And over 2,900 people with HIV were included compared to over 600 controls. And the mortality associated with smoking was compared in people with HIV to the general population. This figure shows the Kaplan-Meier curves showing survival by age stratified by HIV and smoking status. A is all study subjects, B are the males only, C are people of Danish origin only, and D are study subjects who are from Copenhagen. And what they found was that the life expectancy of a 35-year-old with HIV differed markedly compared according to smoking status. For people who smoked, their life expectancy was 62.6 years. For prior smokers, it was 69.1 years, and for non-smokers, it was 78.4 years. So what was interesting is the loss of life associated with smoking was twice as high as that was associated with HIV. And what in the multivariable analysis, including age, year of HIV diagnosis, and excess consumption of alcohol, body mass index, CD4 cell count, viral load, at baseline, smoking actually was the factor that was associated with the highest risk of death. Next slide, please. Sexually transmitted infection screening is important because some patients are still at risk for contracting sexually transmitted infections depending on their lifestyle. As I mentioned, the weight gain is an issue with certain medications, and although it seems like almost all antiretrovirals are associated with some weight gain, and then behavioral risk reduction, counseling patients on safe sex and drug use. Next slide, please. So I work at a cancer hospital, as Dr. Simone knows, and there is an increased risk of developing cancer in people with HIV compared to the general population. And this data was published in Lancet Infectious Diseases, and the authors used data from population-based HIV and cancer registries between 1996 and 2012 in the United States. And they demonstrated that the incidence of many cancers was higher in people with HIV compared to the general population. So, for example, for all cancers, people with HIV have a 69% higher incidence than in the general population. And for AIDS-defining cancers, people with HIV have a 1,400% increased risk, which is not surprising compared to the general population. But even for non-AIDS-defining cancers, people with HIV have a 21% increased incidence of having these cancers compared to the general population. And for people with HIV, there's also an increased risk of developing hematologic malignancies, Hodgkin's lymphoma, myelodysplastic syndrome, along with other non-AIDS defining cancers, including anal cancer, which is associated with oncovirus infection with HPV, along with lung cancer. Next slide, please. So last, I'm going to just move on to prevention. Next slide, please. So between 2007 and 2016, studies demonstrated that there were zero linked HIV transmissions after over 100,000 condomless sex acts within both heterosexual and male-male serodiscordant couples where the partner was had a durably undetectable viral load. And so in 2017, the Centers for Disease Control announced that U equals U, which basically means undetectable means HIV is untransmittable. Which means when people who are having sex, if the person with HIV has an undetectable viral load, they won't transmit the virus to their partner. Next slide, please. So with the knowledge that U equals U, ending the HIV epidemic in the United States is actually now possible. And it's a Department of Health and Human Services initiative that strives to end the HIV epidemic in the United States by 2030. And it looks to scale up 4 strategies that can end the HIV epidemic: diagnose, treat, prevent, and respond. Diagnosing people with HIV is key in prevention. Unfortunately, the uptake of the CDC's recommendation to test people for HIV has not been optimal, and difference in testing by race, ethnicity, and geography continue to persist. And the CDC is pairing up with multiple communities to try to increase and encourage the HIV testing in various populations. And testing is important because you have to identify people to treat them and get them on the right medication, as people who are on the right medication can lead long, happy lives and healthy lives. Treatment isn't reaching all populations evenly, however, and disparities persist by race, ethnicity, and geography. And about 80% of HIV infections that occur each year are transmitted by people who are not receiving HIV care. So providing effective treatment for people with HIV can help prevent further infections from occurring. Preventing new HIV transmissions by using proven interventions such as pre-exposure prophylaxis or PrEP, and syringe services is another way to help decrease new infections. And finally, the last goal is to respond to any new outbreaks to help get vital prevention and treatment services to people who need them in that area. And next slide. And that's my concluding slide. And that's a picture of me with the City of Hope patient. That is Paul Edmonds. He is the 5th person in the world to achieve remission from HIV after undergoing an allogeneic stem cell transplant. He's been off antiretroviral drugs now for 2.5 years, and he's doing amazingly well. Thank you.
Okay, Dr. Dickter, we'll just wait for the room to repopulate so we can start our question and answer session with you. I'll wait for our moderators to pop into the room as well.
So that was one of the. We've been doing shows for a long time, Ray, and we've never came up with that fix. That is something that we were talking backstage. We're going to have to keep that trick in our box because we never considered getting the audio through the person who has good audio. So fantastic job to Dr. Samoa. Dr. Dickter, thank you so much for sharing the information. I think that was a huge. It really gets my attention of the person at the end that you had the picture of, that is one of many, one in many, I guess is a better term, that is in the health condition that he's in, thanks to the hard work and the research and the medical professionals that are doing the job that they're doing. So I think we're waiting for a couple of people to come off of mute. We have Kavehi and Joseph in, but probably a good time. Maybe Dr. Samoa has a question or two that he would want to add. I see that our other moderator is not in, so Dr. Samoa has dropped. Maybe he had connection problems. So, Dr. Dickter, can you hear me? Let's see. Okay, so Joseph and Kavehi, can you turn your cameras on if you can hear me and if you're still there? We've been having There's Kavehi. And I'm going to go ahead and unmute you. Dr. Samoa is back. And there's Joseph. So if everybody can unmute, we're all back and we can begin our Q&A session.
Yeah, I don't see anybody from Mapumaya here, so I guess we can go right into the happy doctors, yeah?
Yeah.
Okay.
Kavehi, Joseph, do you guys have any questions?
No, thank you. That was an excellent presentation. It was you did great with all the technical difficulties, so thank you.
Can I ask a question? So Jana, when you are because I assume that there has to be some communication with primary care providers and yourself in regards to the care of patients. What are a couple of things that you run into that seem to be sort of stumbling blocks when it comes to from primary care providers and patients with HIV?
Yeah, I'd say that I don't tend to have communicate with primary care doctors about HIV so much, but I do communicate a lot with HIV doctors on the outside for the patients we see at City of Hope, the cancer patients, and even just today, we have because of the polypharmacy issues, especially with the cancer population. There's always drug interactions that come up that we need to modify. So I was on the phone today just talking to a person's primary HIV provider because this patient has a very drug-resistant HIV and is on a whole host of drugs which are going to interact with his chemotherapy. So we had to put our heads together to come up with something that A, would work, and B, he would tolerate. So that comes up mostly in my day-to-day life now. But I think the key thing is taking the opportunity to test people is what's key. And I think, I've seen people over the years who, they come to the doctor. One patient comes to mind, and he kept coming to the dermatologist over and over again with one skin rash after another. And he also was, a heterosexual male, so nobody kind of like thought, is there something wrong, immunologically with him? And he ended up having AIDS, and it was, he got it from his girlfriend actually, whose ex-boyfriend was a intravenous drug user. So, the thing is that I've seen people over the years where you don't think of the traditional risk factors, and it can slip through the cracks, and then they can get really, really sick and almost die sometimes in certain situations due to opportunistic infections and their being unaware of their HIV status. So I think the main point would be test. The CDC does not require, the CDC and the state do not require written permission to test people. It is the opt-out approach. So it's almost kind of like if you're getting someone's blood, that you're assuming that they're going to consent to other types of testing. I just simply say to people, I'm going to test you for all kinds of infections, including HIV. Is that okay? And unless someone says no, you can do it, and it's an easy thing to do, and you can really make an impact by testing someone and getting someone diagnosed early on.
Thank you. I guess my next question is for Joseph and Kavehi. I think one of the reasons why Mapumaya brought this topic into our space is because, well, one, they cater to a population where this is a concern, but also because we do not talk about HIV that much in community circles, and we just heard sort of the one of the linchpins of the plan to prevent and get rid of HIV is to test. you know, so in your opinion, what do you think have been some of the traditional obstacles in testing our communities? And what do you think might be possible community-based solutions for us to overcome these obstacles?
Yeah, I think that there's definitely a stigma associated with HIV because it is a sexually transmitted infection, because it's associated with intravenous drug use, and so I think that a lot of people are uncomfortable with talking about it and asking people questions. I think that so I think that's one of the big barriers. I think that when the CDC mentions testing everyone between the ages of 13 and 64, probably one of the things that could be done would be just to try to encourage testing at many point of care sites. So for example, if someone comes into an emergency room for a broken arm and they're and it's the first time they've gone to the doctor in 5 years, it's an opportunity to test. And I think that the ER doctor or the urgent care doctor is not going to be like, oh, I want to do an HIV test on them, and that's part of the problem with our healthcare system in general, right? And so I think trying to capture those opportunities is always a challenge for for everybody. But again, I think the way to do it better is to try to capture people when you can. And a good example is women. For women, when women come to their doctor when they're pregnant, it's there's a stamp of labs they do, and that includes HIV and hepatitis and syphilis and all these things, right? That's part of routine screening. And I think if we were to adopt some of those similar thoughts, not just for pregnant women, but for certain populations, and certainly for more of the general population, we would be more successful in testing.
I see. So Joseph, you just heard reference to the emergency room. How do you approach? Let's say you come across Pacific Islanders in the emergency room. How do you broach the conversation that you want to test someone for HIV? Because the stigma has kind of come into our community too, right? We have kind of the same sort of norms when it comes to what we can talk about, what we can't. How do you, as a professional, as an ER physician, what's the conversation you have with them?
Well, first of all, thank you for the presentation. It's very informative, so thank you. But I think for me, the stigma, especially in indigenous cultures, especially conservative ones, and I'm talking about people like Micronesians and general Pohnpeians, still talking about sex is it's a taboo, So we're still trying to get over that hump, and I think one of the stride that we made so far is our ability to talk about cervical cancer and the fact that it's related to STI. And I think if we build upon that momentum, we can actually capture a lot. To be honest with you, since I practice in Texas, I've never treated a patient from a Pacific Islander, but I would imagine it would be a difficult conversation to have with them, especially if they're of the opposite sex. So, but I think just providing informed consent and just informing them that it's becoming part of primary routine testing that we should be doing, and not to make them feel like we're making an assumption that we think they have it, or we're talking about their behaviors. I think it's really difficult, in my opinion. Yeah, but I think for me, one of the reason why I really I'm glad that you guys bring this topic up is because in the emergency department, I have to admit that I'm not gonna be the one that initiate the treatment for HIV, but one of the things that is really important to me is post-exposure prophylaxis. And I think, I'm a doctor, but sometimes pronouncing those medication itself, it's difficult. So I still have to go ahead and look it up every time I have a patients that have been sexually assaulted that needed prophylaxis. It is during those times that I have to go back and review the guidelines and try to educate myself. But I think nowadays, I think a lot of people are actually not with the post-exposure prophylaxis, but also pre-exposure prophylaxis as well. So I think it's a dynamic issue that we have to continue to not just be informed about it, because the information is out there in the public, and patients are more knowledgeable about the disease and the treatment opportunities than even 5 to 10 years ago. So I think it's an important topic to stay keen on as we continue to practice our specialties.
Thanks, thanks, Dr. Joseph. So, Dr. Ao, same question. Like, with pediatrics and young adults and adolescents that are part of our community, how do you broach the conversation?
I think I just try to normalize it as much as possible. And I mean, hearing that statistic that 13% of people don't even know they have it is really helpful to tell people. Like, a lot of people don't even know. And then I just let them know, like, yeah, this is what we need to test for today. And then anytime you get a new partner, I want you to come back and we'll retest about 3 months after you have a new partner. And then just like you said, talk about safe sex practices and stuff. But just try to make it as normal as possible. Who's that?
Thank you. So with that, I would like to extend our warm thank you to Dr. Dickter for joining us and providing us with a wealth of information regarding this topic. Um, we appreciate your availability and your expertise. Um, so with that, we'll go on. Just some uh, feedback on or just some info points. Am I sharing screen? Can you guys see the CME credit screen? So just so you know, we're offering CME. So for the happy doctors, we sent around instructions for you to fill out so that you can get credit. Um, uh, I think everybody in happy is domestic, so you'll follow the domestic instructions. International doctors, for those of us who are joining from outside of the U.S. and especially in the USAPI, um, we sent a couple people information as to how you can obtain credit by registering first. And so if you have not received any information on it, please email us. Uh, I can drop our email. Actually, our email is on the flyer, but we can also drop it in the chat. You see, it's our Gmail address. Um, and then we can get you signed up so that you can get credits for the future talks. You can only get credit during the live session. Unfortunately, we don't have the capacity yet to do credit on the recordings, but hopefully, fingers crossed, we will be able to do that in the future. Um, Once you sign up after the session's over, you'll be sent an email to complete evaluations. Um, and then you'll also email, let me see, the once you get the emails, they'll ask you to submit the attendance code um, for the live session. So this is the attendance code for this session. If you want to send that after your evaluation um, to the City of Hope, the CME at coh.org email, they'll get you your CME credit. So just a couple housekeeping things. The Pasifika Grand Rounds is every third Tuesday of the month at 5:30 p.m. I know today's not the third Tuesday, but most of the schedule is third Tuesday of the month. Um, If you want to be added to the Outlook, just email us thehappydoctors@gmail. Um, the upcoming Pacifica Grand Rounds is on September 19th. We'll have a very lively discussion about head concussion surveillance and treatment in athletes. As you know, Native Hawaiian and Pacific Islanders have a disproportionate share of athletes in the world, and we are very susceptible to head concussions. So I think it would be very relevant for us in our community to tune in. And Dr. Raul Jandil is a neurosurgeon and researcher who's done concussion work in the Pacific, in Palau, Guam, and in American Samoa. So he should be able to provide us with some really good information. And with that, that's it. If our happy doctors want to stick around as we go offline, we'll chat a little bit. I don't want to keep you too late because it's late over there in Utah and in Texas. But thank you so much for attending our grand rounds. Thank you again, Dr. Dickter, for joining us. And that's it. I'll leave it to Carl to sign us off.
Thank you so much. And thank you, everybody, for attending. Apologize for the difficulties, but hey, doctors fix things, and Dr. Samoa came up with a solution, one that we hadn't been aware of. So we're going to put that in our bag of tricks. Please join us next time on September 19th for our next episode of Pasifika Grand Rounds.